Bioethics 2.0, Podcast Episode 9, Determining Capacity. Bioethics 2.0 Podcast, Episode Guide. This is Podcast Episode 9, and it will cover the ethical process of determining a patient's capacity. You can find this information in Introduction to Clinical Ethics textbook by Fletcher, Chapter 9. Additionally, this information can be found in the Green Book, also known as Practical Ethics for Nursing and Nursing Students by Schroeder, Chapter 5. There is an important difference between competence and capacity. Capacity is essentially the ability to make a decision. It is a crucial element in the process of informed consent. Incompetence, however, is the legal term used when a person has been judged by a court to be completely unable to take care of him or herself and manage his property. A declaration of incompetence completely negates a person's legal rights, and a guardian is usually appointed to make important decisions for that person.
A determination of capacity must be related to the following three things: the individual abilities of the patient, the requirement of the task at hand, and the consequences likely to flow from the decision.
Definitions or standards of capacity, the outcome standard.
If you take a look at the clinical ethics literature and the medical literature, you'll find at least three general standards or definitions of capacity. In the next couple of slides, we're going to take a look at these definitions and understand why two of them should be rejected and one should be preferred. The first definition is the outcome standard. Here, a patient is judged to be capable based on the outcome of his or her decision. So if the decision reflects values not widely held or rejects conventional wisdom, clinicians may actually call into question the patient's capacity. Merely because the decision does not reflect conventional wisdom or values that are held by the clinical team doesn't mean that a patient is or isn't capacitated. On the basis of this standard should be rejected. Clinicians should not be in the business of making judgments about the outcome of a patient's decision. I like to call this free dumb. Free, D-U-M-B. Patients sometimes make decisions that do not accord with what the clinical team would think or want. In our culture and society, we allow patients who are capacitated to make decisions even if we disagree with them.
The category standard.
The next standard we want to talk about is the category standard. Here, what happens is a patient is judged to be capable or not based on his or her category or status. So the patient is said to be incapacitated when he or she is mentally ill, mentally retarded, aged, a minor, or critically ill. Once again, just because a patient has a certain mental or physical status, they should not be judged to be capable on the sole basis of this fact. So just because you have an elderly patient does not mean that the elderly person is not capacitated. You need to do specific tests to make that determination. Once again, on the same basis of the category standard, this standard for capacity should be rejected.
The functional standard.
The functional standard is the standard that should be accepted. This standard recognizes the patient's functional ability as a decision maker. In assessing a patient's ability to make autonomous judgments, there are three distinct aspects of decision-making capacity. The first is the ability to understand. The second, the ability to communicate. And third, the ability to evaluate. If a patient demonstrates satisfactory responses in all three areas, he or she is said to have decisional-making capacity, to be decisional, or to be capacitated. All three must be present in order to be considered capacitated. If one or two is lacking, the patient is not capacitated.
The ability to understand.
The ability to understand is composed of two different tasks. The first is the ability to comprehend the given information about diagnosis and treatment and to identify the issue at hand. For a nurse to test this ability, he or she should ask the patient to paraphrase the discussion. The second is the ability to appreciate the impact of the disease and its consequences. To test this ability, ask the patient to state the major options and most likely outcomes for each option.
The ability to communicate.
Clinicians must also evaluate the ability of patients to communicate. To test this ability in patients who can speak, ask the patient to state his or her choice of treatment options. The ability to communicate extends beyond verbal communication. If a patient cannot speak but can write or use other valid methods to answer questions, then clinicians have the duty to help the patient to use whatever assistance is available so that the patient can communicate. This is what it means to help your patients be at their best.
The ability to evaluate.
The third task is the ability to evaluate. This basically means the ability to deliberate in accordance with one's own values, and the ability to manipulate information rationally and to compare risks and benefits of options. Also included is the ability to maintain a consistent choice over time.
Nurses' role in capacity.
Nurses, as primary caregivers in most healthcare institutions, can assess decision-making capacity. As they are part of the patient's daily care, they can be called upon to assist the medical team in determination of patient's capacity. Often, when a patient's mental state changes, the nurses are usually the first to take notice, and they should relay that information to other clinicians as soon as possible when issues of decision-making are at stake.
Helping patients to be at their best.
Depriving patients of decision-making rights is a serious infringement on their autonomy, so every effort should be made to help patients perform at their best. Nurses can play a vital role in helping patients achieve the capacity of being able to make decisions. Nurses should note that a serious or life-threatening illness or injury may lead to maladaptive behavior with resultant post-traumatic stress disorder or depressive responses. They should be aware of these things and have assessments that can capture these things. In addition, denial of life-sustaining therapy in situations such as this may reflect altered capacity. Hi, I'm David Perlman, Senior Lecturer, University of Pennsylvania School of Nursing, and Associate, University of Pennsylvania Center for Bioethics.
Hello, my name is Ryan Smith. I'm an undergraduate student at Transylvania University, and I'm a philosophy and biology double major with a pre-med emphasis. I am currently the summer intern at the University of Pennsylvania Center for Bioethics.
If there are any questions about this particular podcast content, I ask that you please direct those questions to me at the University of Pennsylvania School of Nursing. And my email, for those of you who are listening on audio, is perlmand, P-E-R-L-M-A-N-D, @nursing.upenn.edu.
Funding for these podcasts comes from the University of Pennsylvania School of Nursing. In addition, we receive support from the University of Pennsylvania Center for Bioethics, the Weigel Information Commons at Van Pelt Library, and the Ormady Music Center, also located at the Van Pelt Library.